Thank you everyone for being with us. This is the fourth wave of the Complex PCI E-Series. We're joined today by the course co-director, Dr. Omar Göktekin, whom I'm glad he could make because this is the first day of CTO Essentials, which is both a fantastic and a very busy meeting. So I'm really glad that he could make it. We're also joined by Dr. Amr Al-Hadidi, Dr. Yasser Sadiq, Dr. Basim will be with us, Basim Abdul Hamid will be with us shortly. Hopefully there's been a slight change in program because Dr. Omar, again, his time was very tight. So on his behalf, I'll be presenting the Understanding the Hybrid Approach talk. Omar, how is the meeting going? Well, I set up the slides.
Meeting is good. Yeah, meeting is good so far. We did 4 cases today. And we had 3 cases from my lab and 1 case from Germany. And tomorrow we have 6. Actually, we have 8 more. What we will do and Italy. So I like
connection.
Again to
Great. Omar, would you try to fix your connection because your voice is breaking up? And I'm not, are you seeing my screen, Dr. Amr?
Yes.
Okay, great. So this is intended, so this is not the proper title. These are my disclosures to get them out of the way. So I will skip the pre-procedural planning part and get straight away to the topic of this presentation, understanding the hybrid approach in particular. So the hybrid approach was introduced back in 2012. Essentially, a group of 13 CTO interventionists met at the time, and that was actually a year earlier, and started reviewing cases with the ultimate objective of trying to understand a pattern, come up with an algorithmic approach that in the vast majority of instances, if you're able to go through it, you will end with a higher likelihood of success. And the algorithm was built with 3 objectives in mind. A, standardizing the approach. So 10 or 11 years ago, I would attend meetings in different parts of the world, mostly presented by superb Japanese operators, but I would be absolutely flabbergasted. I'm completely confused. I don't understand why they're moving from this step to the other, why they're using this wire rather than that wire. So it was sort of very esoteric. So the first thing was to standardize this, to demystify the enigma around CTO PCI, and ultimately improve success rates and do so in an efficient manner in terms of time, radiation, dose, and contrast volume. And this is the hybrid algorithm. And if we go through the procedure, the first step really is dual angiography. And after a proper dual injection, and perhaps if we have time, we can go to that and say how a proper dual injection can be done. You want to identify 2 first key components, whether the proximal cap can be readily identified, a so-called clear versus ambiguous proximal cap, and what is the quality of the distal target. So if the answer to those questions is yes, it is a clear proximal cap, and the distal target is good in terms of quality, then an antegrade approach becomes the reasonable first option. Now, once you've identified that, you move to question 3, which is identifying whether interventional collaterals exist or not. So if interventional collaterals do exist, then the retrograde approach can become a possibility. If they do not exist, then you're stuck with the antegrade approach. The 4th question is related to the lesion length. And in the more recent years, we're looking both at the lesion length and the course ambiguity, whether you can, or you think you can fully understand the course of the CTO segment or not. So if it's a very long segment, i.e. more than 20 millimeters, or the course is extremely ambiguous and you're very uncomfortable sticking your super stiff wires or very stiff wires, then a true-to-true crossing becomes very unlikely and potentially dangerous, and the dissection re-entry technique, on this occasion, antegrade dissection re-entry, becomes the technique of choice. If the answer is that the length is less than 20 millimeters, or it is a more or less straight course that you can understand, then antegrade wire escalation becomes the initial strategy of choice. On the other hand, if the proximal cap is ambiguous, the distal target is of poor quality, then you were thinking of the retrograde approach. Your next question would obviously be, do you really have any interventional collaterals? And if the answer is yes, you move to the fourth question, again related to lesion length, whether it is a short, straight, or more or less straight segment, and wire escalation, retrograde wire escalation on this occasion becomes the option of choice. And if it's not straight or very long, then a true-to-true cross is going to be quite unlikely and potentially dangerous, so reverse cart becomes the technique of choice. Now, the beauty about the hybrid algorithm is not getting stuck in one mode. So let's say you started with a clear proximal cap with a good distal target, you opted for antegrade, it's a short segment, you started with wire escalation. We don't keep trying with wire escalation endlessly. Now, if this is not working, we quickly move to another alternative. So perhaps there is a good distal landing zone, you go for dissection re-entry using a stingray balloon, for instance. If interventional collaterals exist, you can shift straight away to retrograde and finish this with a reverse cart. So one important aspect about the hybrid algorithm is moving seamlessly and flexibly in a dynamic fashion from one mode to the other, but this is there essentially to help you pick what primary approach you choose, which is most likely to be successful. And if we look at how the hybrid algorithm can be extended, now we do face problems at every point. So this is the so-called extended hybrid algorithm, whereby once you get stuck in one mode, what would be your option? So if you're stuck in the subintimal space, a stingray balloon would be excellent. If everything seems futile, a wire-based re-entry sort of as a last resort, a star, and Tariq Rashid explained the different wire-based techniques on wave 3. If true to true is the method of choice, how to use your sequential wire escalation, and if you ended up in the subintimal space, you can always shift to the antegrade dissection re-entry. Similarly I don't want to go through all this, it's a busy slide, but again, this shows you that the hybrid algorithm is flexible. There is troubleshooting under each of the separate 4 headings or 4 techniques we use, and there is also the concept of interchangeability and switching from one technique to the other. So the best thing is to look at an example. This is a totally occluded bright coronary artery. You can appreciate that the proximal LED also has a subtotal stenosis. And if you look, these are beautiful septal collaterals coming in from the LAD. This is the right cranial shot, which shows you a better understanding of the septal anatomy. And this is how we evaluate such a lesion. So this is an ambiguous proximal cap. Let me show you the left cranial shot first. So the right coronary artery has an ambiguous proximal cap. It is exactly at the origin of a marginal branch. The length is around 25 millimeters. The distal vessel is of good quality. There are very good interventional collaterals for septals. No calcifications. There doesn't seem to be any sharp bends within the lesion body. So the plan here was to fix the proximal LED, try not to cover the septal perforator unless we have to with the stent, though you can still easily cross into that septal even if it was stented. Give a brief antegrade trial. If that doesn't work, we move quickly to retrograde wire escalation, and this is the choice of wires. And if the retrograde wire doesn't go through to true, we go to retrograde dissection re-entry. So this is quickly fixing the proximal LED, crossing using a sion wire, and of course, here microcatheter. We reach the distal cap, then we use a fielder XTA wire, and the fielder XTA wire was able to cross through to true and externalize. And finished with a final result. And that was again following, so the first plan didn't work out, the second plan worked out, but that's the whole concept of having plan A, plan B, plan C, and knowing when to move from one step to the other. Now, a few years down the line, the Asia Pacific CTO Club came with an algorithm for CTO crossing. And although in principle it follows the same concepts, a number of distinct variations were included. Essentially, in the presence of an instant CTO, you might want to consider using a cross-boss from the outset. This is based on a single trial, a cross-boss trial, which showed that using a cross-boss in instant CTOs led to a quicker pre-canalization. It wasn't particularly more successful, but it was more efficient in terms of time and contrast. And the whole concept is, once you enter the CTO segment inside the stent, a cross-boss will take you all the way, usually true to true, without exiting the stent struts. The second thing which is different to the Western hybrid algorithm is using IVUS when you are faced with proximal cap ambiguity. So remember, with the Western hybrid algorithm, proximal cap ambiguity would shift you more towards the retrograde approach. Now, this is not always true and definitely not always feasible, because there might not be good retrograde options, or they can be extremely risky. So using IVUS to remove the ambiguity from the proximal cap by identifying it, by visualizing it, is one way to go around such anatomy. The third important difference is that they did resurrect parallel wiring. Now, we've discussed parallel wiring the last wave. We honestly think that it is not something that we should completely forego. It does work, it is simple, it is easy, especially for people early on in their experience, but I assure you, very experienced people still use it. So removing it altogether under the assumption that it is not reproducible is not exactly right. I think the balance here is not to go trying with parallel wiring for 30 or 40 minutes and completely destroy the subintimal space and end up with a large hematoma. So when the antegrade wire approach fails and you find yourself in the subintimal plane, you can consider dissection re-entry or parallel wiring, which is not really meant for dissection re-entry. It is meant to find the true lumen, perhaps by probing the proximal cap at an earlier stage. The fourth and last difference is they do stress the fact that was ignored in the Western algorithm, that it is not just about the vessel or the CTO length. Equally important is the tortuosity of the CTO segment itself. So you can have a 30 or 35 millimeter CTO segment, but in a very straight fashion with a course that you completely understand. I don't think that you would want to go for a dissection re-entry technique in such anatomy from the outset, just because the lesion length is very long. So these are essentially the main variations. So I think it's a good refinement of the Western algorithm. So this is an example of an LED CTO, and we can appreciate that the filling from the right coronary artery is very faint. So there is essentially no retrograde options from the right side, at least. Now, there is a single retrograde option, which is ipsilateral from a large diagonal. And this is a very tiny and tortuous epicardial that goes around the apex and fills the apical part of the LED. So there are retrograde options, but they're not exactly the easiest or the safest. We can appreciate that the proximal cap is entirely ambiguous. It's a flush occlusion with the left main LCX continuity. And this is how we analyze such anatomy. It's an ostial LED CTO, an ambiguous proximal cap. There are two levels of CTO, each less than 20 millimeters. The distal vessel is somewhat diseased. There are interventional collaterals, perhaps a very tiny septal that failed as a matter of fact, and an epicardial from an obtuse margin, rather than the diagonal. And the plan here was to use IVUS to remove the ambiguity from the proximal cap. And if that doesn't fail, we shift to retrograde trials. It's always good to try septals initially, even if they're not angiographically visible. You can end up with good surprises in a number of occasions. And if that doesn't work, we shift to epicardials. And once we decide to do either retrograde or antegrade, you need to wire the circumflex for protection in such anatomy. So this was the wire in the ramus branch. And you can see that we're seeing the proximal cap from the side. This is again a pullback from the ramus branch, and this is the still images. And we end up with a number of quite important pieces of information. So A, we identify where the proximal cap is. we also understand that there is a decent amount of calcification in the proximal cap. So that gives you an idea about what type of wire you want to use initially. This was done a few years ago. So this was a Venture microcatheter. A Venture is a deflectable microcatheter that you can control the tip. It has gone off production for some time, but it should be back on the market very soon. And this was a third wire from the outset, given the extent of calcification we've seen. Now, while we were working with that, we noticed a sudden drop in blood pressure. And the reason was a dissection in the proximal right coronary artery because of the L1 catheter. And while we were trying to reposition, we lost the system altogether, quickly put in a Judkins right and fixed the right coronary artery. And this is, again, an important thing. In CTO PCI, the donor vessel takes the utmost priority. You want to fix any problems. You obviously want to avoid them in the first place. But if problems should happen within the donor vessel, you want to fix them ASAP, and that takes priority. And then we were able to engage the proximal cap, change the Venture for a fine cross microcatheter. And this is, again, an IVUS pullback from the ramus branch. I want to show you a couple of things, so I'll take it slowly. So what you see on the right-hand side is the circumflex. And what you see at 10 o'clock is the wire, the shadow of the wire, going in a very central position inside the proximal cap. So this ensures you that A, you are inside the LED, you're not going elsewhere or somewhere outside the vessel's architecture altogether. And you also know that you are in a central position, which significantly increases your chances of true-to-true crossing. And then it becomes relatively easy. We downgraded to a Gaia second once we reached the mid-LED, did some balloon dilatation, and you can appreciate that the vessel doesn't look the greatest, especially at the distal part. Did an IVUS run to give us an idea about the length of stenting, the size of the stents, and we ended up putting 3 stents all the way into the left main, and this was the final result. So again, a relatively lengthy procedure, 2 hours, 320 cc's of contrast, but this is sort of the beauty of the hybrid algorithm in terms of giving you different options, in terms of identifying what the initial strategy, the most likely strategy is going to be, and importantly, give you an idea when the next step or what next step to move to. And the emphasis here is to try to move quickly. So given that we have some time, we might have the chance to talk about a few ground rules. It is about setting the scene for CTO PCI. This is not part of the hybrid algorithm per se, but these are essential prerequisites or basic components of CTO PCI. You really want to avoid ad hoc procedures. You want to allocate sufficient time. And remember, those are patients who, we don't fast patients overnight as such, but some places do, so make sure they're very well hydrated, especially they can be a long procedure and they can get huge amounts of contrast. You want to prep your alternative access sites so you don't get caught in the middle of the procedure. The urinary catheter is optional, but helpful essentially early on in your learning curve. Adequate sedation and analgesia. Now I can tell you, once you cross collaterals, some patients will become very distressed, a lot of chest pain. When we started our CTO program, we used to have an anesthetist in the room. While this is not a sort of a prerequisite or a recommendation, I found it very helpful in our early days because it gives you essentially a full room to focus on the technical part of the procedure rather than pain relief. And you obviously want to check your indication for intervention. And this is a dynamic process. So if you get a patient with angina class 2, you have a totally occluded right coronary artery, you started to fix it, doesn't work, antegrade, you don't have any good septal options, ADR is not an option, and your only choice is going through a very tortuous epicardial collateral coming from the AV trunk, for instance. Now we really want to stop and revisit the sort of risk-benefit ratio of the procedure and whether we're doing this to open up a vessel or to benefit the patient on the whole. Now with image acquisition, you really want to do your dual injection, that's low magnification, and to be able to do so without panning so we don't lose any of the image resolution. We start with the donor vessel first. We put it in the proper angulation to see the collateral. Then we inject the CTO vessel, ultimately aiming to visualize both the proximal and distal caps simultaneously and understand the collateral supply. And I think I'll stop at this stage because this has been covered in the last talk. Thank you.
Thank you very much. It's great talk. Thank you. So I like your cases today. I think, you know, IOS guidance penetration is very helpful, especially if you deal with the, you know, ostium of the circ or ostium of the LAD. It's really helpful because you can see easily the ostium of the branch. What do you think? For the beginners, I think it's nice to start with the ostial LAD or ostial circ to see better, you know, the proximal cap.
Absolutely, Omar. With ostial lesions in general, I find IVUS very useful because you might finish the case with a simple antegrade wire escalation once you've resolved the ambiguity of the proximal cap, and B, even if you end up not finishing the case antegrade, in the instance of an ostial LED or ostial circumflex, when you go retrograde, you really want to understand where you've recrossed into the left main. So it is very useful early on to stick an IVUS catheter in. It resolves the ambiguity. It gives you a lot of room to maneuver after that.
I like to a question, you know, to you and the other panel. You know, for example, if you try to open one vessel, let's say it RCA, if the wire is subintima, the first wire, then if you have good landing zone at the distal, okay, for Stingray, let's say, would you prefer to do Stingray, or if you have collateral from the LAD or from the RCA, or do you want to go retrograde first? What do you think, Ahmed? What's your opinion? If you have Stingray, for example, still, do you try to go retrograde, or you want to stay antegrade to do Stingray approach?
Excellent question. I think we have a case lined up for live to Istanbul tomorrow that essentially addresses this point. I think this really has to do with the institution where you practice, the operator's personal experience with Stingray, and cost, or the economic side of it. And the fourth thing, which perhaps should come as number 1 or 2, is how good are the retrograde options? So if I were in my place, either in Aswan or Cairo, if I end up in the subintimal space antegradely, I might consider parallel wiring as a first option if I think this lesion can be traversed through to true. I might consider, and if the retrograde options are good, I would go to retrograde first. If the retrograde options are so and so, I would stick in a Stingray. And the reason here is I'm comfortable with doing retrogrades, and Stingrays cost a lot. In other places in the country, they're either not available, or the operator experience, again, because of the cost, is not the greatest. So I think it's different from one operator to the other. Yes, sir, what do you think?
Excellent, Ahmed. I think it's the same, Ahmed, but well, because the Stingray, it's costly, so I would prefer, if there is a good channel, as Omar mentioned, for retrograde, I would prefer first to do retrograde. But if after dual injection, I have some difficulty as epicardial, tortuous epicardial collateral, or something like that for the right coronary artery example, I would minimize my my wires and my stuff to start with Stingray. I think this is a good option, but we should wait. What is the success rate for everyone, for every procedure, and how much it will cost if I go retrograde or if I go by Stingray?
I'd like to ask you, Ahmed, thank you for this great presentation. Very important to have an IVUS tool and to know, because this is one of the best options to find out the origin of the LED. You know, you have a flush total occlusion of LED with the left main. So you need to have the side branch, the CX, to have your chance to puncture the ostium of the LED. This is very important to have. But if you don't have the IVUS tool in this scenario, is that to try to puncture the ostium with a hard wire, I mean, Confianza, for example? What do you think, Ahmed?
Absolutely not.
The landmark will be retrograde wire. So what do you think?
I would be very uncomfortable with, especially in the anatomy you've just seen 10 minutes ago. It's a huge circumflex. And I would really hate to start poking with a CP12 or Hornet 14 when I'm not fully comfortable because the LED ostium could be really anywhere. We had no idea where it is. And even if you put a retrograde wire as a marker, it still shows you the target, the distal part of the vessel. It doesn't really show you where to poke, except if this was a very, very short segment. So
which wire do you start?
One important definition, and I love the way you put it, one important definition for an ambiguous proximal cap is a cap with which you're uncomfortable using a CP12.
Okay.
So if you don't understand where the cap is, you don't poke with a CP12.
This is a very important message. That's why I'm asking you this question, because the attendees must know that if you have a stump like this ambiguous cap, so the IVUS tool is very important, because you will find out at least you are in the track, not outside the vessel. This is very important. And also another important point is that when you have a guiding at the right corona, this is very important. And this is where you're doing the donor vessel. You need to protect yourself and also put a wire in the RCA, because this is, as you mentioned, and what happened in the scenario that you put a stent, which is very important. It's life-saving.
I fully agree with Ahmed and Amber. We have to be very careful if we don't know where is the proximal cap. Yes. Yes. It's easy to to penetrate the vessel, and it's very easy to cross outside the vessel.
Okay.
So I think there are no further burning questions at this point. And we can move to our next presenter, who's going to sort of put theory into practice. My dear colleague and one of the most talented operators in the region, Dr. Yasser Sadiq, is going to present a case scenario on retrograde CTO PCI. Yasser, go ahead, please.
Welcome, Amr Zaki.
Welcome, Am. I'm fine, thank you. Nice presentation, Ahmed, as usual. Huh?
Welcome, Dr. Am. Sorry, you came inside in the middle of the talk. We couldn't welcome you on board. We're also waiting from Muhammad Jailan from Nairobi, but he's en route.
The network is very weak in Nairobi. He just posted that in chat.
Yeah, he should be showing up shortly. Yes, sir. Sorry, go ahead, please.
Okay. Thank you, Ahmed, for this nice presentation. Thank you for the distinguished faculty. I'm really happy to share with you case. This is a case done 1 month ago, but it's a little bit difficult for the decision and for the anatomy. This is a female patient, 67 years old. She had all risk factors: hypertensive, diabetic, dyslipidemic. She has family history in brothers, and she is morbid obesity. She did CABG 15 years back. She did Lima to LED, vein grafted to obtuse marginal, and radial grafted to right coronary artery. She complaining of exertional angina with minimal effort since 1 year ago, and she did muscle ICT at that time which showed that she had patent lemma to LED and patent radial graft to right coronary artery, and she had occluded graft to obtuse marginal. So she did the PCI to LCX with to the left main with 2 stent at that time, and she is okay with medical treatment. But 1 month before her presentation to me, she admitted in the cardiac unit with non-STEMI and acute chest pain, and she was in maximal medical treatment to control her chest pain. And after that, this is her laboratory finding. She has normal ejection fraction, and she had high cholesterol, hemoglobin A1C 7.9, and she did coronary angiography after this attack and showed occluded radial graft to this right coronary artery. And she had patent stent to LCX and the patent lemma. She was in maximal medical treatment for 2 weeks, but she complained chest pain with minimal exertion. So we decided, after we revised all her coronary angiography and multi-slice CT, to do for her this right coronary artery. This is dual injection, so we can stop here and hear from Omar, Ahmed, Dr. Amr Zaki, Amr Hadidi, everyone. What's your plan in this case? You hear me, Ahmed?
Yes. Let's start with Dr. Amr Zaki. But
Can we
keep the loop running, please?
Yasser? Yeah.
I will, yeah, this is
Yeah, it's 15 years occlusion now, huh?
15 years, yeah.
Yeah, so it's tough occlusion. I can't appreciate from this view if it's heavy calcific or not. But you have a problem with maybe there is a side branch at the just at the occlusion. I'm not sure it's at the beginning or not, because it's I can't see from here. No, yes, it's at the beginning of the occlusion. So this is a little bit difficulty. The lesion is more than 20, and I have a concern of 20 millimeter, because I think we should change it to 30 or 40. 20 is not a big deal. But here, maybe I'll start Antegrade first. This is an option. I can see the distal right is, there is another, maybe CTO or subtotal occlusion. So maybe it's double occlusion, but I think Antegrade would go. If not, then okay, we'll go retrograde. But retrograde, it's epicardial collateral, as I can appreciate here. So it's a little bit difficult. No, it's epicardial something.
Yasser, I don't. Yeah, I think Yasser. I think we have one proximal CTO here. I don't think there is a CTO at the distal. If there is a good collateral from epicardial to serve to distal, so it fills RCA distal nicely. Proximal part filling from the bridge collateral. That's why it seems that there is another occlusion at the distal part, but I don't think there is definitely there is good channel there. So the only CTO is for me at the proximal part, and the proximal cap looks like tapered. I wouldn't say it's ambiguous cap, because if you look at the right oblique view, I know where is the cap is. So I like to go from the right oblique. I need to go straight. It's obvious from it's very nice that we have a right oblique view. So
I think Yasser, Antegrade wire escalation is the best option now.
Yeah,
Especially
we have a good chance, right, guys?
We have a good chance, like Omar said, that we have maybe if you change the view, maybe sometimes you can find the track small tip in the occluded segment, so you can go with the wires. What do you think, Yasser?
But you remember that this right coronary occluded now for more than 15 years.
Yes, sir. Yes, sir. I'm sorry, I have a question.
Yeah.
Would you explain when to differ epicardial collateral intervention? I mean, you said it's post-CABG. Of course, it's more dangerous because there is no pericardium to contain even the perforation. But when to use and when to avoid epicardial collaterals, I mean, as a teaching point of view, not about these cases only.
Yeah, this is a very good question, Haitham. I think when you have the chance to go antegrade, and when Omar asked a few minutes ago about Stingray, if we have a distal landing zone, good distal landing zone, not in this case, I would prefer to go with Stingray and to avoid epicardial collateral after CABG. Because it's if something happened, it will be fatal. So this is the case. So I am totally agree about the plan you suggested, Omar, Dr. Amr, to start with antegrade approach. What do you think, Ahmed Gindi?
I totally agree with what the panel has said. I was just wondering whether anyone on the panel would think differently. I think I see a channel at the distal part, so I'm not really concerned about that. It is diseased, but there's definitely a connection. But our main problem really is the proximal part. And again, it is a tapering proximal cap. So chances are relatively reasonable or good with an antegrade approach, albeit that your target, again, in the mid-right coronary artery is somewhat diseased. So this is a case where if there were a straightforward septal collateral, I might have considered going primary retrograde, but given that this is an epicardial collateral, it's quite usable in all honesty, but I wouldn't want to use an epicardial collateral as a first option. So I would go antegrade first.
Yeah. I think this is a good option. Yeah.
After dual catheter angiography, and according to lecture of Gindi, we have to decide if we have clear proximal cap, good distal target to start with antegrade or retrograde. And as Omar mentioned, there is not clear 100%, but I thought that there is a stump. I can put my microcatheter and do antegrade escalation wire technique. And this is what I did. This is retrograde injection to see the retrograde of the right coronary artery, and I started as antegrade wire escalation, and this microcatheter is carvel microcatheter. I started with filter first, but honestly, I spent here a lot of time trying to do antegrade approach with multiple wires. I escalated from Filter XT to Gaia, SIR, to Conquest to Blue 12, and the Hornet 14. And here, as my mouse here, you have to see there is a bulk of calcium here. It's very hard. It's this segment, and you can see the wire prolapsed. This wire, it's Hornet 13. You can appreciate how is it very difficult to go antegrade. And after a lot of trial, I decided to go retrograde because it's a very difficult penetration. So as Omar mentioned, and Gindi, everyone mentioned that there is a good epicardial collateral, but be cautious. And this is retrograde epicardial. This is the same microcatheter, carvel microcatheter over sion black. And
sorry, Ether, what wire did you use for the epicardial collateral?
This is sion black, Ahmed.
Okay.
Okay. And after I reached here, the same point, it's very difficult to penetrate from retrograde at this point too. The same point. It's very calcific segment.
But
and
yes, sir, didn't use SUHO 3. I don't think you don't have. We have.
Yeah, so I have SUHO 3, but it I keep this wire with tortuous epicardial because it's an expensive one, and when you have only channel for epicardial, it's difficult, and when the sign can't cross this tortuosity, I would prefer to go with the SUHO wire. But it's a good epicardial collateral.
Sorry, is that difficult to cross by sion black in this collateral? How difficult was it?
It's not so difficult, Omer. It took about 5 minutes. The only difficulty to go from the epicardia from the start, because the ostium of this artery, it's not clear in this wider view.
Changes the wire, the retrograde wire?
The BMW wire, I did for BMW 2 curves to cross this segment, and after that I changed the BMW wire to the sion black wire, and sion black wire did the job. I have the SUHO wire in my shelf, but the sion black did the job, Omar.
Okay.
After that,
you can say you're trying to save money, yes, sir. That's perfectly fine.
Very important. So at this step, yes, sir. We want to think together. Which wire you'd like Ahmed to start to change this wire with a more stiffer wire? What do you think? Sometimes when you use them, for example, after that one, we can use Gaia, for example, because when you have the retrograde cap, I think sometimes when you have difficulty to cross with very heavily calcified antegrade trial, so I think if you have go retrograde, I think sometimes you can puncture it. What do you think?
Yeah, at this point, when both wires are really close, I would want a sort of a penetrative wire. So at this stage, I'd go to a Gaia 3rd or a CP12. I think they're very close to each other, and you just need something to penetrate that.
And I think they are moving together. Do you see? Yes, yes. I think
very close. I think there is a calcium. There is a calcium, between those wires, like occlude the result. So I, because we know where we should go, we can use here extreme stiff wire.
Yes.
Like Astato 30, for example. Mostly we use it 20 or 30. Mostly we use it for peripheral. But here, because we know where should we go, I think we can use that kind of very stiff wire here. What do you think, guys?
Yes.
Yeah, Omar, actually, this is a very good option to go with the stat wire in this situation, because it's inside the lumen, and this is a calcific segment. I can't reach both wire together. So the stat wire will be a good option, but actually we haven't here in Egypt. And personally, I haven't stat wire. I escalated my wire retrogradely, Dr. Amr, the same manner. I tried Gaia 3, Conquest Pro 12, and Hornet 14, but there is no way to penetrate this calcium at that level.
There was a side branch here, so I would recommend, to do anchoring, because I saw a very small side branch, but still we can do some anchoring there. If we do anchoring, we have more support.
Anchoring for the antegrade?
Antegrade, yes.
Yeah.
Anchoring the guiding, this LA guiding.
Option, Omar, I think this is 7 French guiding caster with guide liner. So it will be difficult to go with balloon and the guide liner in the same 6 French guiding caster, I think. Sorry, 6 French left ambulance and 7 French XB. So it's difficult to go with balloon and to do anchoring and guide liner. And
also an important message, yes, sir, that usually, I'm sure this was the setup and the availability, but you'd usually go for a 7 French or an 8 French guide for the antegrade or for the CTO vessel, and for the for the feeding vessel or the collateral vessel, you can use a 6 French or a 7 French, whatever. But always for the antegrade vessel, you want to use a bigger guide because it helps with the support, and again, it gives you the different options,
sometimes you need
including
additional,
if you would use a Stingray.
Sometimes you need additional tools. It's better to have a
Yeah, exactly. So this is getting interested. So you're stuck now. Both wires from both ends are unable to penetrate that tough calcified part. There is no astato, either 20 or 30 or 40 on shelf. And this is the situation. So suggestions from the panel or the participants, obviously.
I saw that Amr Mansour also did the same comment like us. He is suggesting anchoring balloon again. I think another option could be retrogradely tip injection of that Carlino technique. Give some contrast to have some dissection there. That's also I think could be option to go retrogradely. If we do some dissection there, retrograde wire could maybe penetrate proximally.
Is it possible for knuckling in this scenario? What do you think?
They tried the knuckling. He said they tried knuckling for 60
tried
minutes.
knuckling?
I think that's the whole point, is how to resolve this is an unpenetrable proximal cap.
Yes,
and you have many options.
But to do anchoring, did you do by dilatation of the proximal vessel with larger balloon, dissection at the proximal part, very proximal? Did you do that, or balloon assistant dissection?
Subintimal entry. Yeah. So this is Yasser obviously attending to an emergency in the lab, but I will try to cover the points that were brought here. So you want to modify the compliance of this cap. And you can either do so by Carlino, hydraulic dissection, as Omar suggested, or the other way is to go around the cap altogether.
This is the best.
To be able to gain entry into the subintimal space, a balloon-assisted subintimal entry that is using a non-compliant balloon that is sized 1-to-1 to the proximal vessel, aiming to induce a dissection plane that you can get into and go around the cap with a knuckle. The other option is to use a balloon in the side branch and do what we call a side base. So you essentially create a dissection plane at the junction between the side branch and the proximal cap. And this is where you enter. You can enhance your support of the system by doing a power knuckle. So you have your microcatheter and have another balloon next to the microcatheter, fix the microcatheter against the vessel's wall, and this would give you tremendous proximal support to push the knuckle through. You can also do try to rupture a balloon wedged in the very proximal part of the cap. And this is again trying to modify the compliance of the cap, or what we call granuloplasty. So these are all options once you get stuck into this mode, and we sort of escalate with the simpler measures first. I think on this occasion, what Omar said would make the perfect initial sense, is just try to enhance your support by an anchor balloon. So Yasser, what did you actually do?
Very good suggestion. I like all what you mentioned. This patient is morbid obesity, so I prefer to go 7 French, but I started as right femoral and right radial. And when I have a female, I do prefer to go radial 6 French, but I changed for dedicated radial. She's 7 French.
Yeah.
And this is after that 7 French guiding caster with guide liner and pilot 200 and small balloon 1.2 by 10. And I did knuckling, and I succeeded to advance my guide liner, as you can see. And as Dr. Amr mentioned, the two wires are nearby, and this is very important when you want to do reversed cart, because you have to go many views, and to go you have to be very close, especially in the lateral view, especially in iliocranial view, in case of the right coronary artery. to see how the wires are closed from subintimal to true lumen. And after that, what I want to do now, to do reversive cart assisted by this guideliner.
So there are some comments from Dr. Amr again. He's talking about move the cap. Yes, this is the one part is the balloon assisted subintimal entry. You can scratch the cap again, or scratch and go as we call it. This is using an extra stiff, ideally CP12 or Hornet 14 to gain entry again into the subintimal space and change that for a polymer jacketed wire. I think Yasser essentially moved a combination of all the above. So Yasser, so what wire were you able to finish the reverse cart with?
Antegrade is 100, and in retrograde is this guy a second. And yeah, after that, this is the situation. I have RG3 wire, and I'm trying to cross the distal point to do pre-dilatation. But this is 2x12 balloon, and can't cross more than this. And when we did some tension on the system, the patient arrested. So it's very difficult to compete in this situation. So I ignored the distal part because I have a big dissection from reversive cart in the proximal right coronary. So I prefer to stent this to be able to inject antegradely and to see what is the situation in the distal right coronary. And this is 3 by 0.5 by 38.
But yes, you cannot see distally some flow, or what? Or you see, or you saw some flow.
Now I see this flow as you see here, but
no, I mean before the stenting.
Before the stent?
You have any retrograde flow, or you are in a hurry to finish?
I still have retrograde, but the retrograde didn't reach the proximal right coronary artery. Okay, just at the site of the total occlusion at the PL branch. So I prefer to do stenting here, and this is the situation, as you can see here. And this is, as Dr. Omar mentioned in the beginning, this is a heavily calcific part at the distal segment. So 1.5 millimeter balloon crossed, but 2 by 15 new one balloon didn't cross. And after we make some push, the patient, the hemodynamics deteriorated, and the patient moved to arrest. So
so why do you think this is happening, Yasser? Is it too much tension on the system and you're essentially squeezing the base of the heart? Or is it because the retrograde filling is compromised by the microcatheter and a bit of concertina?
I think is the first one suggests Ahmed, because I have some tension in this epicardial vessel. Every time I did some tension on the wire and to trying to force the balloon to cross, the patient arrests twice. So I have, this is after 3 hours working. So I'm sure that there is no harm for this epicardial, as you can see here, and this is the situation.
So Dr. Amr Al-Hadidi, how would you take it from there?
I think we need to put a wire antegradely through the PDA.
To stop here after 3 hours working, or to complete the work?
If the patient
I think you reached the point that the patient is stable. Yes, no pain, and good flow. And I think this is one of the options to stop because you have a lot, the team is exhausted. And I think you have a good flow distally. Yes? And the distal, but if I have some time or less contrast, maybe I would try to put the wire, another wire Antegrade into the PDA.
Yeah. So
and then use a small balloon again. You can use one and
I think this is going to be difficult because with all the support you're getting from the RG3, he's still unable to cross. So I'm not sure whether...
I know, but at least you don't have the tension and the problem that we have, and you're afraid to push because you have, as Yasser mentioned, that you have always strain in the epicardial collaterals. So
I want to make use of another wire in the PDA, perhaps advance your guideliner a bit and take your chances.
I think you can push the guideline, as you mentioned, in the stent. You have a good stent now in the RCA, so you can put your guideliner inside the RCA, and you can easily push. I think you could be encouraged to push, yes, because when you are pushing and fixing the heart with the RG3, I think you have a lot of hemodynamic instability. That's why you don't push at least continuous pushing.
Yes. Yes. So you didn't break the calcium at the distal,
or you
right?
can break the calcium. Yeah.
Did you do that or you didn't? Yes, because patient had cardiac arrest.
I think so.
You couldn't.
He was only able to get a 1.5 balloon in, but trying to upgrade that to a 2.0 balloon didn't work.
Okay, I think there is severe calcification. We may need the rotablation in this patient for the distal.
This is an option. Yeah,
exactly. I think at this point in time, the quickest and safest way to fix this is to get a microcatheter antegrade over your RG3, put in a rota wire and rotablate the distal RCA. This is, in all honesty, the most efficient and quickest way to resolve this. There's a question from the panel, from the audience, sorry, Dr. Jassim. He's saying, did you IVUS? I think it was going to be difficult to pass an IVUS catheter into the distal right when a 2.0 balloon is not getting through. I don't think he IVUS the proximal part, again, because of the hemodynamic situation. He really wanted to fix that proximal part. So Yasser, what did you actually do? We're all eager to know.
So I prefer to go to complete this procedure, and I did the wire in the BL branch and the body wire beside this wire, and the 2 by 12 balloon crossed. And after that, I used Score Flex balloon. It's a nice balloon and a good option to break this calcific lesion, and I succeeded after that to cross a stent there. Distally, this is 2.75 by 34 millimeter, and as you can see here, the well expanded stent in the distal right coronary artery. But the drama didn't stop because the BDA was nice before pre-dilatation, but now, as you can see here, the BDA had some black shaft at the site of this dissection. So I crossed this by sion wire, and this is 2.5 by 15 millimeter balloon, and I want to simplify the procedure, so it's just balloon, and I will see after the stenting what will happen. So the third stent here, it's Retrograde stent 3 by 30 millimeter onyx stent here, and this is the final result. So after that, this is the final result. And you can appreciate here, this is the coronary sinus filling. And this is the end result of right coronary artery. This is the final result.
I think this is a good result, Yasser. And as I said to you, you have encouraged to push. If 2 wires, no problem. You have a guideliner, you can push and dilate. I think this is a good result, yes.
Yeah, sometimes, and this is actually good to see, sometimes the RG3 leads to a bias on whatever devices you're introducing. So the more you pull the edge of a balloon, I've had it with a stent before, finds it even more difficult because of a lot of bias against a particularly calcified plaque, which is relatively eccentric. So this was a good demonstration of different techniques. Having said that, Yasser, how long was the procedure?
It's about 4 hours.
So in hindsight, when you go through it, would you have done anything different, given that we were talking about the hybrid approach and how to make CTO PCI a more efficient process on the whole? So would you have done anything different?
I think Ahmed's most of time consumed in trying to do knuckling antegrade or retrograde, and this is very hard because of calcium. Suggestion of Omar, it's very good to go from the start to anchor this small branch, but I think you have some feelings this is not why of support. This is a calcific lesion because horny protein didn't cross this calcific part. And I think the clue here is that as you mentioned, that the knuckling goes outside this calcific part, and after that I can't introduce my guide liner and did reversed card away from this calcific part. But I think the calcium in the proximal right coronary and in the distal right coronary, I think is time consuming in setting of CTO. But the retrograde and the antegrade approach didn't take time because always we have to have a plan. If we failed for escalation wire technique, in about 30 to 35 minutes by all wires, I will shift to retrograde. And when I shifted to retrograde, it's not difficult to go this epicardial, but my problem and my time consuming to do knuckling at this calcific point. And you know well, it's some cases you have to do knuckling. And it's very difficult to do knuckling. So this is the situation.
Yep. The carvel doesn't help either. It's obviously very good for the epicardial collateral and safe, but it doesn't really give you enough support for knuckling retrogradely. So that might have been another problem as well, one which is not particularly addressable. Omar, there's a question from the audience, and I have a second question for you. Question here from Dr. Jassim is, when do you really stop in this situation? So let's say after fixing the proximal part and you end up with the difficult distal part, would you consider stopping at this stage, and how would you assess the situation on the whole? Unmute yourself, Omar, please.
In this scenario, for example, if we have some dissection at the distal and if I lose my wire, in that time I might stop. Yes, I might stop there, and I could wait one month to have sealed distal vessel. This is one reason to stop this kind of cases. And if in these patients, obviously, Yasser, was able to dilate this calcified lesion. If he failed, I think we have to stop because we need rotablation in that situation. Basically, or of course, patient might have unstable situation or pain or hypotension. In that time, of course, we have to stop.
So I think to summarize, with you making a lot of progress and you're close to finishing the case, and in the absence of compelling problems essentially with the patient, I think it doesn't really make a lot of sense to stop. If any of those are shaken, Omar put in a very good scenario where you already have extensive dissections, you lost entry into the distal true lumen. So this is going to be a very long procedure after an already long procedure. That is reasonable to stop. But when you're so close and you have one technical problem to overcome and you have the tools and the experience to do it, it becomes a bit counterintuitive to consider stopping. Now, Dr. Amr Al-Husseini doesn't like you, Yasser. He's saying lucky that drama was not completed with a nice perforation at the site of heavy calcification. Now, perforations are never nice, but anyway, apparently he doesn't really like you. Now, we're glad it's an excellent case with a lot of take-home
Yes,
message.
I have one comment. Yeah.
I have a last question. We're waiting for Dr. Bassem Abdel Hamid, for Dr. Amr Al-Hadidi, Dr. Amr Zaki, and effectively Omar, Riyad, and everyone on the panel. What is your, if you end up in a position for reverse cut with both the antegrade wire and retrograde wire in very close proximity, and you have the option of using a new wire retrogradely, what is your go-to wire for reverse cut? Omar, and when would you consider choosing? Unmute, please, Omar.
So you're asking for ADR again, or?
No, for reverse cut, you have both the antegrade wire and retrograde wire very close to each other. They're dancing beautifully. And
yes,
you have the option of getting a new wire from the shelf to use retrogradely for recrossing. So what is your go-to wire?
You mean as a first wire, or which wire failed? I have to see.
No, you haven't really tried. You knuckled antegradely, you knuckled retrogradely, both wires, but the retrograde wire is ruined, and you have to get a new wire to try your reverse cut.
Yeah. I think, yeah, I like Gaia second in that scenario, either Gaia second or Gaia third. You know, but if I did knuckle from retrograde and if I did knuckle from retrograde, so I think we have to go with the hydrophilic wire with knuckling, because in that time we are in the subintima from the antegrade and also subintima from the retrograde. No need to go from true lumen again and the false lumen in that scenario, you know, because this is a good scenario, by the way, because you are in the subintima, antegradely and retrogradely. I would continue with the hydrophilic wire.
Yeah. Yes, sir.
I'm totally agree with Omar. The same. I will go with one of Gaia, and then if field I like one of hydrophilic wires as pilot family or filter family.
I think Ahmed, a good option to start the Gaia family, Gaia second or third. And if you cannot go, you can do knuckle with the pilot 200, for example. I think this is a very good option to reach the subintimal space and try to get to the true human antegrade.
Dr. Amr Zaki?
Yeah, same. It's a pilot 150 or 200, and maybe Gaia second. But I have one comment, if you permit.
Yes, please.
If before the body wire, it was great to take the body wire because this was one solution. The other one, didn't you think to take the antegrade wire and then take the balloon 1.5 and then go with the guide liner just very distant, and you can push? This is an option also.
This is a very good option, Dr. Amr. But honestly, I tried this in the beginning, but the guide liner, the assisted balloon, didn't go except in the middle of the stent, and they stopped there. Okay. So I tried to go more deep with this guide liner, but it stopped at the mid proximal stent. So I shifted to another option, body wire, and after that I used the Scoreflex balloon.
Okay, which body did you take?
The body wire was pilot 50.
Pilot also, huh? Because Asahi also is a very good option to take it as a...
Putting in a Grand Slam or a VHW would make perfect sense on this scenario.
Okay.
So I actually try, my first wire, in all honesty, for recrossing is usually a pilot 200 or a Gladius more recently. I find those very easy to navigate. And if that doesn't work, I would go for.
You mean Gladius ET14, my dear?
No, a regular Gladius.
Okay, today I use first time Gladius ET14. I like it a lot. It's very similar to Pilot 200. I like that wire. I use Gladius wire, but the first time I used it in the coronary, that wire. Gladius
ET14. I haven't tried that one before. So I've tried the Gladius and the Gladius Mongo, and both are perfect wires. In all honesty, the Mongo comes with the added benefit of knuckling without having a very big knuckle. But I find them very useful for reverse cuts. So perhaps I go differently. I try first with a Pilot or a Gladius. If that doesn't work, I get a Gaia second or third. So these are excellent cases. I think you have one more slide with the take-home messages before we move to Basim, who hasn't showed up yet. He's still stuck in traffic.
My take-home message: retrograde CTO needs a gradual ascending learning curve. Retrograde CTO needs a very good setup. It's very important. Retrograde via epicardial post-coverage carries fatal complication. Be cautious, and you have to be trained to deal with the complication. The antegrade or retrograde knuckling is difficult in highly calcific total occlusion, and you have a lot of options, as Omar and Gendi and everyone mentioned. Retrograde CTO preferred in the long total occlusions to avoid antegrade dissection re-entry and losing the important side branches. In CTO, don't stuck in the failure mode. CTO first, do no harm. Thank you so much.
Thank you very much, Yasser, for an excellent.
Thank you, Yasser. Great.
Very informative discussions. Now, I think Basim has not, is still stuck in traffic. So I guess that leaves us with me having to share one case on the antegrade approach with you. Let me see if I can start sharing. So apologies from pulling this from the middle of a presentation. This is meant to be the second case of the day. It's for the antegrade approach in general. This is a 60-year-old gentleman, smoker, hypertensive, diabetic, complaining of angina on mild exertion, preserved ventricular function and echo with hypokinesia in the mid and apical anterior wall, and with viable myocardium on his CMR. So these are the setup shots. I think this is really all what I have. So if you want to make any comments, now is the time for it.
So I think, Ahmed, you have after the LED, the occlusion, you have a branch, a small branch diagonal at the site of occlusion, but I think you have a small stump. It's not seen well in this.
No, I don't see a stump from where I am. It might be the resolution.
No, I mean you have a small. If you change maybe the view, or you don't have, I don't see the whole film, but I think there is no obvious stump. Yes.
Yeah, there is no obvious stump. I remember we looked carefully in different angulations and we couldn't see any stump.
I think from the epicranial view, you know, I could guess where is the proximal. What do you think? Just after diagonal, I like to penetrate that part, you know, with the Gaia first, for example.
Yep.
Not or Gaia second, not that stiff wire.
Usually start with Gaia first.
I mean, here, yes, I can try Gaia first. Mostly I try Gaia second, just, you know, knock the door. Maybe it can penetrate easily. To me, this is not ambiguous cap, to be honest with you, because I know where is the cap.
I think there is a cap, maybe.
A blunt cap. It's not very ambiguous, but it's a blunt. It's not tapered.
It's blunt, yes.
Okay, so you would start, Omar, with the Gaia first, given that we hardly see any calcification, and
you can use IBA's guide, Ahmed, as well.
Yes.
To reduce the number of wires, I think we can go for a second. What do you think? Because you know that a lot of wires can use. So
for me, Amr Zaki, I'm going to start with the Fielder XTA. If it failed, I'll go to the Gaia third just directly. And the IVUS is an option. And I think Ahmed is going to do an IVUS for this case. IVUS is an option to do an IVUS through the diagonal to confirm your position. But I think Antegrade is could be done here.
Okay, so these are all, I think, Antegradely, yes, we did think that this is an ambiguous proximal cap. At least it looked ambiguous to us at the time. The distal vessel is healthy. I think one thing that wasn't mentioned is the source of collateral filling. So the LED starts filling immediately at the distal cap.
From the
and the only source here is a septal to septal collateral,
yes.
yeah. And what we failed to identify early on, and I actually had to revise the film afterwards, is that while this looks like a nice V-shaped septal to septal, there is a figure of 8 tortuosity at this part where it goes from the descending to the ascending part. So this under the thigh branch here. So this was pretty tricky, and it came to haunt us later on, having failed to identify that loop early on. So our interpretation was this is an ambiguous proximal cap, a healthy distal vessel, ipsilateral septal to septal collaterals, and a relatively short lesion length. And the first thing was to try to resolve the ambiguity with IVUS guidance, go for antegrade wire escalation. If that doesn't work, given that the distal vessel is very healthy and there are no branches as such at this part, we go for an ADR. And if this doesn't work, we go for the septal to septal collaterals. And this was the initial IVUS trial. The only problem is this part of the vessel was quite tight and the diagonal branch was small. And this is perhaps why Omar and Dr. Amr and some other people on the panel didn't really mention IVUS guidance as a first option.
Who will choose a dual microcatheter? Do you think Ahmed is a good option?
It was an excellent choice, and we actually ended up doing that.
That is not good.
We couldn't.
Ahmed, hear me?
Yeah, go ahead. Dr. Amr, we hear you. Dr. Amr? So I'm not sure, can you hear me?
Can you dual lumen microcatheter is a good option?
Yes, it's an excellent option, but our first priority was
you hear
to...
Me?
I can hear you. Can you hear me from my end?
I hear you, but I am asking you if it's possible to use dual lumen microcatheter from the start.
Yes, that's an excellent option. We did end using a dual lumen microcatheter, but our first priority was to identify where the proximal cap is exactly. So we tried to do live IVUS guided penetration, but because the diagonal was a small branch and there was a lot of disease at that bifurcation, so it was very difficult to do live guidance. The microcatheter with the IVUS catheter, it was getting very sticky. But we did use the IVUS to give us an idea about the exact site of the proximal cap, and again, whether it was calcified or not. And we tried to use different wires to go through that proximal cap, but we always ended up going into the diagonal. And this is where we did exactly what you mentioned, used the dual lumen microcatheter to get us into the proximal cap, then advanced the regular Corsair microcatheter on this occasion. You ended up, obviously, you can see it is dancing with the vessel, but it's definitely outside the true lumen and very far away. So that one chance here, or one option here, was to go quickly for an ADR, but obviously with this position and this distance, ADR was not the best option. So yes, we did some trials aided by the dual lumen microcatheter, which we re-advanced over the Gaia third wire, and did trials to reposition another Gaia third wire. We were still unsuccessful. So this is, perhaps this was the earlier picture. We reintroduced the system again, a dual lumen. This was a fine duo or a twin pass microcatheter, sorry. Tried to find a different entry point from the beginning, again with CP12 on this occasion, which managed to get into the CTO body. And then we started de-escalating for a Gaia second. Unfortunately, the Gaia second also failed to make any advancement, and we decided to knuckle all the way to resolve that ambiguity and go for an ADR. Now, the second problem, you can recognize it that the knuckle again is moving in a different plane, probably towards a very small diagonal branch. And we weren't comfortable pushing that knuckle any further, so it was difficult to move at this stage. So this is the time where we started, okay, so we might go through that septal to septal collateral. We did multiple trials, but because of this figure of 8 loop and the presence of a side branch at the apex of the loop, we always ended up not being able to go to the ascending part into the septal. So this is where we effectively ended up re-advancing another system, Antegrade, dual lumen microcatheter, but get a pilot 200 on this occasion. And the pilot 200 did something beautiful. It essentially ignored where the initial knuckle was going, and it ended up in the subintimal space, very close towards the true lumen. You can see it sitting right under the vessel, and then stuck a Stingray balloon in over a Miracle 12 wire. Did a stick with a CP12, did a double-blind stick, both in upwards and downwards. And then this is a pilot 200 moving towards the upper part of the Stingray balloon and moving very smoothly into the distal part of the vessel. So we ended up, after doing an ADR, you don't really want to inject Antegrade. We did an IVUS pullback, and I want to draw your attention to two things. You can start noticing here from 12 to 6 o'clock, there is a big subintimal hematoma. We are in the true lumen, and we know that because there is vessel architecture all round, but this was the very distal part. It was from the repeated Antegrade trials with a big knuckle initially. And then this is the part where we're in the subintimal space, and you can see the true lumen and the vessel being compressed between 12 and 3. So there are two different problems here in the vessel. So this is in the distal part where we're in the true lumen. This is the slightly proximal. You can appreciate that this is still the true lumen, but we have a large subintimal space, crescentic in shape, and this has vessel architecture. And this is at the site where we deliberately went in the subintimal space. You can appreciate the IVUS catheter is in the subinterstitial space, and the vessel is compressed on the right half of the image. Now we proceeded with placing a number of stents. This was in the middle of a trial we're doing on self-expanding stents. So we put a self-expanding stent distally and an Onyx 3533 stent proximally. And this is the now the Antegrade shot we have. So any suggestions, you can appreciate that immediately distant to the stent, we have this compromised vessel. And I will stop at this stage just to get your insight on the panel from what do you think we should do next?
You think if you use a small balloon milking in the distal part of the stent to help you to enlarge the distal LED? What do you think?
So that was considered, but I knew from IVUS that this was a healthy part of the LED. We obviously gave GTN, so it's not spasm. And
but it looks in the IVUS is not so small like this.
No, it's not small. It's definitely much worse now.
I think if you leave it there, sometimes it will grow, definitely. It will grow.
Yeah, that's one option, Omar.
I would do some balloon massaging here. It would be nice. 2 balloon, for example.
Okay. So if there are no other suggestions, we looked at the IVUS images again, and perhaps I can take you back to that. And we thought this is a subintimal hematoma, which is now squeezed between the distal edge of the stent. Now we're absolutely
cutting balloon, yeah.
This is true lumen, yeah. And so this is a subintimal hematoma. Now, while a massage can definitely make it look better, but it will probably squeeze it even further down the vessel. So we thought that one way of getting across this is by using a cutting balloon.
Yeah.
So this was a 2.5 cutting balloon. Sorry, we had to fix the diagonal initially. Then we used a 2.5 cutting balloon. And the cutting balloon on this occasion, this is again because we have very good understanding because of the IVUS images. We're totally comfortable. We know that we're in the true lumen. We know there is a large subintimal hematoma. And one way to resolve this, especially Dr. Amr mentioned that we can leave it, which is true. On this occasion, it was at the very distal part of the stent. We thought it might be compromising the outflow. So after one single inflation with a cutting balloon, which essentially aids to release this hematoma, this was the final result.
Great.
Very good result. Ahmed, I think this your case now. Tell us why, as CT operators, why we should learn and why we should use, ADR technique, Stingray technique. I think because you failed from Antegrade, you couldn't use retrograde collaterals because they are not suitable. They are not interventional the collaterals. So the only option stays Stingray. So I think all of us, should have it in our lab, and then if we need it, we have to use it. Very good example for that.
Totally agree, Omar. So we've spent quite a few years without a Stingray on shelf, and I can tell you its presence gives you yet another option, and sometimes spares you the difficulty or the hassle of or the complications that might come with squeezing yourself into a very tortuous or difficult collateral that you really wouldn't choose if you had another option. So yes, have it on your shelf is always something good and will come in handy. I see Bassem has joined us now. I'm sorry, Bassem, we had to present the case, so we'll keep you for our next wave. But thank you very much for joining. I know how traffic can get very ugly.
I'm so sorry for being late, but I think it's a very heavy traffic. I'm 3 hours just to reach home. And I saw your case. It was a very, very great case. And thank you for replacing me, Dr. Ahmed.
Thank you, Bassem. Always a pleasure. Now, I will just try to attend. We have Dr. Amr Farnawani. Is there a risk of perforation with the use of cutting balloon? No, we've hardly seen it. We don't have any real data on that, but we've used it repeatedly. That includes myself and other CTO operators, and there is no risk of perforation. This is not oversized as such. It's sized to the vessel, and essentially it does a number of clean cuts to connect the hematoma and release it into the lumen, and those usually heal beautifully. Using another stent distally to squeeze the hematoma might actually be dangerous because you'll essentially push the hematoma further down the vessel, and this is a smaller part of the vessel, obviously, so you might end up with a worse situation than what you started with. And I think there are no other questions, so at this point, I will stop for any last comments from Omar, Dr. Amr, and Dr. Amr, and Haitham, and Bassem, and Yasser.
Giddy, I have a comment or a question. Sometimes while doing some interventions, either CTO or occlusion anyways, you can get some septal hematomas. It's really a septal hematoma, but the patients deteriorates markedly. Do you think it's some sort of vagal stimulation or something like this? It's not effusion, but the patient's got a drop in the blood pressure and manifestations like a tamponade, but there is no effusion with the echo. Do you think it's some sort of vagal stimulation with the septal hematomas?
So Omar, do you want to get that? And I can sort of answer after you. Yeah,
sometimes we could have hypotension, it could be a vagal reaction. Patients may have, a full gallbladder, for example. It may give us hypotension. We have to check, of course, also if the patient has, a catheter, urine catheter. That's important point. Or we might have sometimes if the patient have, if the patient didn't have any water from the morning, for example, and if the patient late afternoon, it may be because of the hypovolemia, because we give nitro and other drug. That's also may affect, those patients had easily hypotension because they need volume.
Yeah. So these are It's always good to have an algorithm to face hypotension. And usually the first thing I look at is I want to make sure that neither of my guidings is causing a problem. One of those problems is causing AR, which can only present by worsening hypotension. And while this usually happens with your amplats, not infrequently, and even an XB or an EBU can cause that if it's too much seated, too deeply seated in the aortic root.
Very good point. Very good point.
And this can really drive you mad because you start looking for many reasons, and you find that just pulling the guiding back sorts everything out. You want to make sure that you don't have any problems with your donor vessel. So that would be my second thing. Do an echo to rule out any pericardial effusion. That would be my third thing. Then I would, if I'm fully comfortable, I would say, yeah, probably this is a full bladder, or sometimes we don't really know the reason. Sometimes it's just vessel overstretch if you're especially ballooning in the subintimal space. But to be very specific for your question, Haitham, it's with septal hematomas, we need to be very cautious. While they're notoriously very safe, they are self-limiting, but sometimes they call a dry tamponade type because you essentially end up with a dissecting hematoma that keeps enlarging, and you do echoes and you don't have any pericardial effusions. And if this is situated in a part which is in the far field of the echo, you can occasionally get a progressively enlarging hematoma that compromises the chambers, either the LV or RV or both. And there have been reports on this being a fatal complication. So it's important when you end up with a septal hematoma, the decision whether you coil it or not is multifactorial. Some people have a very low threshold for coiling. I personally don't, but I pay attention to following up those patients very closely and make sure that neither of their chambers is compromised, including the AV group.
Perfect.
So, Dr. Amr.
Yeah, another comment, you did mention it. It's very good point. When you're using dual lumen microcatheter, sometimes you're going into the false lumen because you're too deep. So if you take it another, just proximally a little bit, you'll go from another plane, and then the second wire, you can go to the true lumen. You have mentioned it. So I'm just raising up this point.
Thank you, Dr. Amr. So Omar, any final comments, again, for mostly focusing on how to think of the hybrid algorithm, especially for people who are just starting their experience with CTO PCI?
No, I think you touched all reasons for hypertension. Very important points. Thank you very much for that. I think we are done for tonight. What do you think?
Yes.
Yeah.
We are down, and we have a long day tomorrow, I'm sure.
Yes. So as usual, be great cases and great talks, great discussions, great questions from the audience. I'm very happy to be here tonight. Thank you all, Ahmed and the other colleagues. Thank you very much.
Omar. Thank you very much, all the panelists, and most importantly, thank you everyone from the participants. And we look forward to seeing you in our next wave of complex PCI, which is going to address essentially calcified lesions. Thank you, Dr. Amr. So we'll give you the closing remark.
Yeah.
You're just in for the closing remark, so you can close the session. Thank you very much.
Thank you, Omar. Thank you.
Thank you.
Thank you.
Evening, everyone. Thank you.
Thank you.
Bye-bye.